Imagine the epilepsy you have, the seizures you have, that is, electricity is going through your brain, right? And it has good ways to go and bad ways to go. And in your case, sometimes it's going a bad way. And so what does neuromodulation do? Neuromodulation aims to maybe get at that source and just change the way that electricity happens, how it acts.
I'm Kent Leidy, CEO of Cadence Neuroscience.
And I'm Doug Sheffield, Chief Scientific Officer.
You're listening to Seizure Diaries, where we explore all things epilepsy and explore the latest developments in epilepsy science and therapy.
Together, and with expert guests, we discuss the impact of epilepsy and the work being done by Cadence Neuroscience and others with the ultimate goal that every person lives a seizure-free life. Welcome. Pleased to introduce Scott Perry, the director of the Jane and John Justin Institute for Mind Health. Pleased to have you with us, and I know our listeners are going to be excited to hear more about your work and the work at Cook Children's Hospital, and it's a pleasure to have you here.
Pleasure to be here, Doug.
Scott, I'm fascinated about your journey to becoming a medical director of neurology and co-director of the Neuroscience Center. It's very interesting to see about your interest as a child about the space program and becoming an astronaut.
Mm-hmm.
So I think our listeners would love to hear a little bit about how you got into exploring a different type of space, the space between our ears.
Yeah. Okay. Well, yeah, that's pretty simple. When I was a kid, I wanted to be an astronaut, and I was pretty serious about it. And at space camp, they told me that because my vision was not perfect, that I was not going to be able to be shuttle commander. Anybody who knows me and my personality, if I'm not going to be shuttle commander, then you're probably not going to find me on the shuttle. So I tossed that dream to the side and said, let's figure out something else to do. And then just becoming physician and a neurologist was just about finding something challenging. And then it was what made the most sense. And neuroanatomy made the most sense. Neurology rotation made the most sense. And then got into neurology residency and became fascinated by the story of epilepsy itself. I focus most of my time on rare genetic epilepsies and epilepsy surgery. And to be able to sit down and listen to a complex, often a very complex story that has told itself over many, many, many years, and to listen and to, peel out all the details of a seizure to understand where it comes from and why it comes from there and how it happens and what you can do about it is what drew me to do what I do now.
Well, I remember the first time we met and we talked to you a little bit about art therapy and the ability to see the effect of neuromodulation on the actual EEG. And I think you lit up. I think you thought, wow, that's pretty cool that you're not just stimulating and not seeing what the effects are on the EEG. Tell me a little bit about that.
There were two things that were exciting. One was that, I can't solve every intractable epilepsy by going and taking out a thing, a single, small area or whatever, right? A lot of these epilepsies are very complex and broad, and they have big networks that need to be dealt with. And you can't go take out both sides of the brain, for example. So, you guys were offering an opportunity to at least cast a wider net to cover more area. And then when you covered that area, potentially doing something to that area and seeing that response to know that what you're doing is worthwhile before you commit even, and go all the way and implant a device, leave a device there. You've got something objective to say, okay, it's clearly there's some response coming from what we're doing, so we're on the right track. That's novel and exciting.
One other thing that really impressed me on my visit was the room full of attendees. I didn't know much about their neuroscience group, but I realized in meeting this group that there's a lot of interdisciplinary and collaborative efforts. Tell me a little bit about how this environment impacts patient care at Cook Children's Hospital.
Yeah, just thinking about epilepsy in general, especially like epilepsy surgery, yes, it requires a big team. When you were here, I'm sure we had the neuropsychologist, the neurosurgeons, the neuroradiologist, our epilepsy nursing staff, et cetera, in the room, right? And you need all those people to think through a case and hopefully come to what's the best decision for the kid we're taking care of. But yeah, the Institute for Mind Health, which wasn't quite open when you were here last, is taking it a step further, because it's one thing to plan the surgery, but it's another thing to care for the entire patient. And they often need more than just the neurologist and a neurosurgeon or even the neuropsychologist. So this floor also has the departments of psychology and psychiatry and developmental pediatrics and physical medicine and rehabilitation, pain medicine, as well as our Neuroscience Research Center. And all of those groups have such overlap over the care of the patient. When you put all those people on the same floor, and I can just walk down the hallway and around the corner and talk to a psychiatrist or a developmental pediatrician if I've got a question, then I can maybe do something right then and there for the kid instead of having to wait on a consult. And it's amazing what you learn when you interact with each other every day. Some of the things that you don't know how to ask the right questions to probe to figure out what's going on, or you're not really sure what direction to go with treatment, how much you can learn from, just having the colleagues around, asking those questions a few times, you start to get the answers, and, really, really helps provide better care.
Seems like you've done a really good job getting the word out about the Cook Children's Hospital and how this is a good place for folks interested in learning more about epilepsy.
Cook Children's exists somewhere in between traditional academics and private practice, which really gives us an opportunity to be a little more nimble in the things we do and to kind of think about how we do things a little bit differently. When I first came here to Cook, I saw a place that, we're seeing 40,000 or more outpatients in neurology clinic alone per year, and, doing, 50, 60 epilepsy surgeries a year, but there wasn't a lot of research production. And the reason for that is because I had a staff of clinicians whose job was to see patients, and that's what they did every day. The idea that there was not some research being drawn around it to the degree that we needed was what really drove me to, really push to create the Neuroscience Research Center and get ourselves a team that is, here to do that research around all of this work that's going on.
I want to take us down a little different path. This is our first time we're really looking at a pediatric patient population and listening to you about how informed the parents are about their child's epilepsy. I think you made a comment once that sometimes the parents might know more than the resident who might be seeing the patient. So I want our listeners to get a little better understanding of the parent's role in the decision-making process for what options to pursue for their children.
Yeah, well, the caregiver's role is essential. Look, there's two pieces to it in general. So first of all, the job of the physician or the advanced practice provider that's taking care of the kid is to offer them basically everything that is available. You have a right to know every option that is available for you. Each of those options will come with risk. Each will come with benefits. They all have some amount of efficacy. Some may have more than others for individual cases. So the job of me and my staff is to provide that information. And then the next part of my job is to try to help the family make a decision of what is best for them, what fits best with their goals for their child, what fits best for their family situation, what they're prepared to do. And so the families often come in pretty educated. If they're not fully educated, we try to have the time and resources to let them become educated. No one needs to make a decision right this second. Get the information you need. Ask the questions you need to ask until you're satisfied with where you go. And when we're talking about epilepsy surgery, epilepsy surgery is not a benign treatment. It's a big step. So you need to be absolutely sure that you feel comfortable with what you're doing, where you're doing it, and what you expect to happen.
And I assume in this, the child or the pediatric patient also has a voice. And how do you elicit that?
Yeah, absolutely. If they have the ability to make those choices, we definitely want them involved. At the appointment alone, they're given the opportunity to ask the questions that they have and get the answers they need. Here at Cook, we do something called surgical preparedness, and we have a visit with one of our psychologists who has a number of questions around surgical readiness to really make sure that both the family and the patient understand what they're doing, what we're evaluating for. And then if we're going to do surgery, are they prepared for surgery? Because it's more than just, I'm going to go get a temporal lobectomy. All right, that's a one-day thing. But after the temporal lobectomy is done, then there is recovery time in the hospital. And then you're going to get out, and maybe there's some activities you do now that you're not going to be able to do for a period of time afterwards. Maybe there's going to be, some medicines you need to take, or some other precautions you need to take for a certain amount of time. Maybe there's a risk of, some adverse effect. And do you understand what that means? Are you thinking about all the other stuff? For the family, the kid's going to have surgery. There may be a period of time where you have to stay at home and you're not able to go to work for that period of time. Is that something that can be done? So, I mean, there's just a lot of thought that has to go into it.
Are there any common misconceptions that people walk into the clinic with that you find yourself, having to educate them and help them get a better understanding?
Misconceptions of epilepsy in general, or epilepsy surgery?
Yes. It seems to me a lot of people don't completely understand it and don't understand what the risks are oftentimes. SUDEP oftentimes is not well understood.
Sure. Yeah. Okay. So I think there's a few things. Let me answer both. Okay. So in epilepsy in general, misconceptions. I think one problem a lot of people have is just understanding what epilepsy is. As sad as that is, that's like the simplest misconception.
Yeah,
right?
exactly. Yeah.
Epilepsy is the tendency to have more than one seizure. So if you have some reason or tendency to have more than one seizure, you have epilepsy. Too often people don't even use the word, right? And they say,
Right.
you got a seizure disorder, or you got seizures, and then they're like, well, at least I don't have epilepsy. No, you got epilepsy. It's a common thing. Okay. So that's step one. Then, the next thing that I think is really important, especially when we're talking about newly diagnosed epilepsy, is to understand the typical course, or just, statistically on average, what happens, you've got
Okay.
just general,
Here's the road we're starting down.
yeah, in general, yeah, we're going to start a medicine. 60% of people or so are going to be seizure free on that medicine. We're going to start at the lowest dose we know works. That dose does not work for every single person. It's not an antibiotic you take for 7 days and everything's better. It's a medicine you have to take every day. That dose may not work for you. That doesn't mean the medicine doesn't work for you. Maybe we just need to go to a higher dose. If we get to the highest dose and it doesn't work, we're going to go to another medicine. You've got about another 15% chance of becoming seizure-free on the second medicine. If that second medicine doesn't work, then your likelihood of becoming seizure-free with the next medicine is not zero, but it's also not a high number.
Mm-hmm.
And so at that point, you certainly need to be thinking about what else is out there. And so that gets us into a discussion about epilepsy surgery and dietary therapy and other neuromodulation strategies. And, people often think of surgery as a last resort, and it's anything but that. It in general needs to be considered sooner, especially when you're talking about surgeries where seizure freedom might not be, a high likelihood, but seizure reduction is very likely. People like to push that to the end. And I remind people that essentially after you've failed 2 medicines, almost everything you do is more likely to reduce seizures than to render somebody completely seizure-free. So pretty much everything we're talking about falls into a category. And so everything should be considered in that category. That's when it's our job to really say, hey, here are all the options. Which one fits best
Mm-hmm.
for you and your goals, to get you where you want to go?
We talk about this at every American Epilepsy Society meeting about the referral gap between community centers, let's say, and centers like your own. There's been a persistent gap. It sounds like something you're concerned
Yep.
about working on. What can we do about it?
Well, I'll start it on a positive note. We're making some progress. The age at referral for epilepsy surgery specifically, the age at referral is decreasing. All right. So that's good. But we still got a significant gap. I think there's a lot of, just going back to misconceptions, still a lot of misconceptions on the risk of the procedures. I think there's a lot of still understanding we need in what the actual outcome is too, right? I mean, the family comes, they want to know, what is my chance to be seizure free? What's my chance to be 50% reduced, 75% reduced, whatever? And there's so
Right.
many variables that go into that. It's really hard to be absolute.
It's kind of a long answer.
Yeah.
Yeah.
So we certainly want to get to those answers, more if we can. And that was actually, I'm going to jump topic a little bit here, but that was part of what drove me to create the Pediatric Epilepsy Surgery Database, which is part of the Pediatric Epilepsy Research Consortium.
Oh, so you'd have some more data behind your answers.
So yeah, we started that database to collect data on every child that was evaluated for epilepsy surgery at Cook, because we wanted to understand, maybe what predicted best outcomes or complication rates, or what were the features of people who we ultimately said, you're not a candidate for surgery, because maybe that would help us select people for surgical evaluation better.
Mm-hmm.
And that project, has expanded now. There's 35 U.S. centers that participate in that database
Oh, wow.
now. There are almost 5,000 patients in that database. And so then we can go and we can look at that and start to get that information, like who is being evaluated for epilepsy surgery in this country? When are they being evaluated? How are they being evaluated? What are their outcomes? And what's the impact of, waiting longer versus waiting, shorter and stuff. So a lot of good answers are coming from that, to hopefully get us to a point where we're able to provide much more patient-specific, tailored information.
Yeah, that seems to be the age we're in, where these big data collections are getting assembled and we're learning how to mine them and look for things we couldn't have found in years past.
Yeah. And I mean, like I said, we all do, to some degree, epilepsy surgery a little bit differently. We all do the evaluations a little differently. We all have a different threshold of who we think's a good candidate versus a bad candidate. And
Yeah.
I don't know which one of us is right. And so in creating a trial where we say, hey, I'm going to do it this way and you're going to do it that way, is not likely to happen. It's just too difficult to design something like that. But you can take the natural way that it's done. We naturally are doing it differently, and compare those ways in similar patient populations and start to get a feel for which way might be the best ways. And then you can improve upon it. We did we did a real cool study recently where we just looked at the duration of the evaluation. We want to know, like, once you're referred, how long does it take to reach a decision of if you're a surgical candidate or not? And across 35 centers, the durations were very different. And there were certain patient characteristics that were much more likely to result in taking a long time. For example, if you had a magnetoencephalogram as part of your evaluation would be 10 times longer on average than a person that did not have a magnetoencephalogram.
Is that an indication that their MR results were problematic and they had to go to fancier imaging?
Yeah, their results may have been non-lesional, or maybe you needed more precise localization. But the point was there were certain things that make it longer. So one question you want to go back to that feeds into the next question is, okay, well, if magnetoencephalogram makes it longer, does it add anything, right, outcome-wise? And we're looking at that kind of stuff. But the other thing we did almost immediately was look across the centers and say, okay, MEG, for example, adds time, but some centers it doesn't add that much time. And if it doesn't add that much time, what is it they're doing at that center that makes them able to do it so much more efficiently? And so now we're in a process of doing some process mapping. And if we can figure out like what the process is at a place that can do it efficiently, then we can replicate that at the other sites and then shorten the overall duration of epilepsy surgery. We went after that because, when you talk about the delay to surgery, we have focused so much time on trying to identify candidates and get them there earlier. And we made a little bit of progress. And we said, you know what? Probably what we have even more control over is how long it takes us to do the evaluation once they get here. Since we actually have control over that part, instead of trying to educate the whole world, which, we still want to do that, but let's make sure our own system is like super efficient as well.
I want to jump in just for a second. The database that you have and the institutions that you're involved with, that was instrumental for us, as you know, in terms of reaching out to sites that have a higher surgery volume, higher invasive EEG monitoring, and want to get your sense of, are we seeing an increase in overall over the last 5 or so years in SEEG procedures and in actual surgical resection procedures? Is that changing?
I think you're definitely seeing an increase in stereo EEG procedures. Stereo EEG is largely replaced our traditional approach of strips and grids and things of that nature. So you've definitely seen that. Are you seeing more people that may have previously been considered non-candidates, not good candidates for surgery, that now are being considered because they can undergo invasive EEG with stereo EEG and get a procedure? Yes, I think so. I'm not going to say I can prove that with the data I have in my database yet. Not that I can't, it's just I haven't looked at it yet. But I can tell you my own experience, like here at Cook, people that you wouldn't have investigated in the past because, maybe you need to monitor both sides, right? And to do craniotomies on both sides and plant a bunch of grids is a pretty invasive thing. Whereas doing a stereo EEG, we can cover more area with less and get more information. Yeah, we're much more likely to go looking in those cases than we would have before.
The other thing that I've seen, and I don't know if your database supports it, is in talking to these sites, the number of sites now that are adding thalamic SEEG electrodes to gather data. Is that, again, a trend that you're seeing for pediatric epilepsy?
Yeah, it is a trend that people are adding it in the, obviously the neuromodulation of the thalamus is increasing, but yes, monitoring the thalamus is increasing. In fact, we've got one of our projects within the surgery database is specifically looking at stereo EEG monitoring of the thalamus and its subsequent long, impact on what we decide to do and how the procedures, what the outcomes of the procedures are.
One of the areas that I know is a big interest for yours are some of the genetic epilepsies. And again, my understanding is that a lot of these lead more to generalized epilepsy. And what do you see down in the future of, neuromodulation seems so far been more focused on focal epilepsy. And where do you see neuromodulation providing some potential benefit for some of these genetic epilepsies?
Well, I think a few things there. Yes, genetic epilepsies in general do tend to be more widespread or generalized patterns. So definitely the use of thalamic stimulation or stimulation that can cover wider networks is probably going to open up neuromodulation more and more to these instances. I think that again, that was something that came out of the database. We did a paper a year or two ago on epilepsy surgery in the genetic epilepsies, and looked definitely at the monogenetic conditions that lead to focal lesions. Tuberous sclerosis, a fine example. Of course, they do well, but we looked at channelopathies and ones that are more diffuse, things like Dravet syndrome and CDKL5, things like that. There are procedures that we can perform, not just neuromodulation, things like corpus callosotomy, for example, that can have meaningful impact to these kids with these epilepsies. So, for us, the point we were trying to make again is it's our job to go over all of the options you have available. And in the absence of precision therapy for some of these genetic epilepsies, epilepsy surgery still belongs, on the table of offerings that we need to consider. It's not going to cure your genetic epilepsy. That's not what it's going to do. But will it offer meaningful seizure reduction above and beyond what might be expected with additional meds, with dietary therapy, with other neuromodulation strategies, whatever? You got to compare them all.
So we hear a lot of talk about epilepsy being a network disease or network phenomenon. And then I think about genetic causes, and I think of it as more like a substrate kind of effect as opposed to a network effect or connection effect. How do you reconcile those? Do you see changes in neurons and cells and things like that as having a modulatory effect on the network? Or how do you take these kind of two different concepts and work with them?
Yeah, I don't know. I mean, as it relates to genetic epilepsies, I guess it depends on the genetic epilepsy. You have some like Dravet syndrome, which, the problem is highly expressed in the inhibitory network. So one of those networks is not working so well.
Okay.
The other network may have worked just fine. Now it probably got beat up over the years because the other network didn't perform. But I think we see there's the ability to change the trajectory of that condition, right? If you don't use the wrong medicines early, then they're going to have a better outcome, and so that's probably because there's a network impact there.
This is because of what you're avoiding subsequent or further damage from continuing seizures.
Yeah, correct. To use Dravet syndrome as example, sodium channel mechanism drugs are contraindicated. So kids that are exposed to a lot of those early in life, where a lot of important network stuff is happening, are probably set back to some degree, right? So avoiding that is great.
Hmm.
You get better seizure control early in life. It appears you get some better outcomes. I'll say the kids I see now with Dravet syndrome seem to be doing vastly better than ones I saw a decade plus ago, right? We got medicines now that
Interesting.
really reduce seizures by a high amount compared to what we had in the past. So I think there's definitely some potential to not only what the underlying genetic thing is, but what happens when that genetic thing isn't controlled and the network has to,
Hmm.
you know, kind of create itself, in another direction, if you will.
So still room for us kind of network-oriented thinkers to bring that tool set to discussions of genetic epilepsies.
Yeah, I think so. I said, you're not going to solve a whole problem. There's a network that you're going to address, and that's not going to take care of the underlying genetic thing. It doesn't make the genetic thing go away.
Right, exactly.
But if you're modulating that abnormality, you can still have a positive impact, it's just like using an anti-seizure
Hmm.
drug, and the anti-seizure drug is gonna help the seizures, not making the genetic issue go away.
Right.
So while it may not be as disease modifying as a precision therapy that's trying to correct the genetic thing, you would think that there's still some positive impact from it.
One of the things I've heard you talk about, Scott, is about the importance of hearing a patient's story of epilepsy. Every patient's different, every patient's unique. And one of our premises at Cadence is that in order to design a neuromodulation therapy, it's not necessarily one therapy is going to fit for everybody. Place the electrodes in this location, and every patient should always be this stimulation parameter. And as we move forward, while they're in the epilepsy monitoring unit, it's an opportunity for us to really tease out what's unique about this patient. Where would you put electrodes and what parameters? So there's an individual aspect that seems to motivate you, seeing people's lives change. And that's oftentimes requires that individual approach. So listeners, if they have children with epilepsy, they see their child as unique and special and not just a number. So love your thoughts.
Well, a couple thoughts. Number one, I don't know where this is going to go, long term with what you guys are working on. But I kind of got a feeling for a place it's going to fit in. There definitely are places where things are in boxes. They're big boxes. So within that box is a lot of things that fit, but they all can have some differences, but they can be treated kind of similarly, right? In the cadence box right now, I'm seeing those kids who pretty wide network where maybe I wouldn't be satisfied with, a small area of cortical stimulation, nor would I be satisfied with the lambic stimulation. I've got restrictions on what I can do, and I certainly can't resect it. Disconnecting it's not an option either. Right now, what I have at my disposal is more widespread neuromodulation, like with something like VNS, or I got dietary therapy or more meds. So I see cadence as something that's going to give me one more tool there to possibly offer those groups. And then, to your point, within any box for any procedure, every kid's got some, kind of differences of what the risk and benefits are and how they're going to do. And I think that we'll learn that about this procedure over time. But the fact that we can get some of that real time feedback before we make our final decision, if you will, is certainly encouraging and exciting.
Well, I know we're excited about it and excited about working with places with investigators like you and places like Cook Children's Hospital. I've been super impressed with the passion, the excellence, and I think that's a great place for us to learn together. I think I've said to everybody that we're working with, it's a journey, and it's a journey that we need to take with the clinicians and the patients and the families.
Yeah, well, we take it together. Like with any treatment that we investigate, we want to have a pretty good feeling about, first of all, that it's feasible and it makes sense. All right, that it's got some decent science behind it, that it's worth a try.
Yep.
Obviously, also important is that it's reasonably safe when balanced against the outcomes otherwise. And then once we get there, this is just dialing the knobs, fine tuning it to make it as absolutely effective as possible, and of course, as safe as possible.
We talked about, explaining epilepsy to patients and explaining the possible different care paths and what do things look like? Here's the road you're on. What are the milestones along the way kind of thing. How do you explain neuromodulation to patients and families?
Yeah, well, I mean, a few ways, I guess. One is kind of explaining, imagine the epilepsy you have, the seizures you have, that is, electricity is going through your brain, right? And it has good ways to go and bad ways to go. And in your case, sometimes it's going a bad way. It's bad electricity that's creating the problem, right? And so what does neuromodulation do? Neuromodulation aims to maybe get at that source and just change the way that electricity happens, how it acts. We're trying to do that by going to it and changing it by interacting with it somehow. And then kind of the next talk is just understanding that, when you think about your epilepsy over time and how your epilepsy has changed over time, for example, like that's effectively neuromodulation to some degree, right? Over time, networks have occurred. The way those networks interact with each other have changed, and you kind of manifest this story. And so when we put in this device that is going to neuromodulate or try to interact with that network, it may not fix it right away because it's going to have to continue to do its work and modulate and stimulate to try to change that direction of, how things are going, how those networks act, to get the result you want. So I think people have to understand that, like you didn't get to the place you were overnight necessarily, and you're not going to get out of that place necessarily overnight.
Mm-hmm.
It's going to take some time, fine tuning, getting it to the point where it is, delivering what's necessary to get you the best outcome.
Yeah, because a lot of times there's a fairly protracted process where people keep improving, right? So yeah,
Yeah.
it's always. I mean, I'm an engineer, so neuromodulation makes perfect sense to me. And then at the same time, I realize I don't know if we named that correctly.
Yeah.
I don't know if that's really telling everybody on the street what we're all about.
Yeah.
And so I'm always curious to know if people have come up with a great description.
Yeah, and I mean, there's multiple instances like that. I mean, we were talking about genetic epilepsies before, and we've got these disease-modifying therapies we're working on right now. You can't expect that you're going to get that therapy, and all of a sudden the next day, all of your problems are solved. The seizures aren't going to disappear. You're not going to have normal development. Your behavior issues not going to go away overnight, right? But over time of experiencing this new, better working channel, this, better network, we'd expect better outcomes, but it's going to take time.
I want a Schoolhouse Rock video. Remember those? Something like that explains neuromodulation. That's what I'm looking
Right. Yeah.
I nominate you. Hey, as we talk to some of our guests, sometimes we hear about hallmark events. We found out about Danny Did having a marathon in Chicago, and I think one of our folks is going to participate. Are there things like that happen during the year at Cook Children's Hospital that we could potentially support or participate in?
Oh gosh. Well, what kind of great things do we have? I have so many things I'm involved in. Here at Cook specifically, we make a big deal out of Epilepsy Awareness Month.
Yep.
We often have some activities around it. The city is usually lit purple, or at least we try to. Now, I don't take like full credit for that because we are the TCU Horned Frogs in town, and their color is purple. So
purple.
I'm at a slight advantage for getting the town lit purple. We sometimes have some educational series that we do. We work with the Epilepsy Foundation a lot, which of course has walks and things like that around town that we want to be involved in. I'm very involved in multiple groups. As I mentioned, the Pediatric Epilepsy Research Consortium, one, the national organization promoting collaborative collegial research. So there's opportunities there to get involved. And then if you really want to have fun, Child Neurology Society meeting, I am helping host the Child Neurology Foundation's Beauty of Neurology event, which will include karaoke and neuro art auction. So it's going to be a really fun event. So yeah, there's all kinds of places to get involved.
You're a blues fan. There's no blues singing involved or anything like that, is there?
I mean, hey, it's karaoke. You pick what song you want.
Scott, at the end of our episode, we'd love for our guests to point our listeners to any websites or links that you think would be helpful for them to learn more about epilepsy and to consider ways that they can participate.
Yeah. So I think there's a few ways. I mentioned some of the organizations I work with earlier. With regards to just what's going on here at Cook, just go to cookchildrens.org/neurosciences, and that'll take you to our website for the Institute for Mind Health. You can see all the good stuff that's going on here, including our research. I'm a big fan of the Pediatric Epilepsy Research Consortium, so I think people should go there and see some of the new innovative stuff that's happening, not just at Cook Children's, but across the 90 plus institutions that participate in that. So that's PERC epilepsy.org. So I encourage people to check that out. And then a great resource for easy to understand information and frankly, provision of services, including like social services and other things like that sometimes people will need with dealing with epilepsy. The Child Neurology Foundation is an excellent resource, and that's just childneurologyfoundation.org. A great place to go see what they've got available.
Fantastic.
Great. Thank you.
Well, Scott, thanks so much for your time today. Really appreciate having you on as a guest.
Yeah, you bet. Thanks for inviting me. Always good to talk to you guys.
Yeah, good to catch up and looking forward to a productive new year up ahead.
Thanks again.
You bet.
Thanks so much for joining us for Seizure Diaries.
We hope you find these conversations helpful. If you do, we hope you'll consider sharing our podcast with others.
Everybody says it, but it really does help others to discover the show when you rate, review, and share. You can find Seizure Diaries wherever you listen to podcasts.
We'll see you next time.
You're getting better at this.
You say that every time.